Petcha Kucha is a Japanese word for chit-chat and is the name of a presentation format created in Japan in 2003 by Astrid Klein and Mark Dyson, two architects looking for a way people can share their work quickly and simply in public. Since then, the idea has spread to over 700 cities around the world. At every Petcha Kucha night, creative thinkers come together and share their ideas with only 20 images shown for 20 seconds each. Petcha Kucha, a fast, fun format. Find a location. Join the conversation.
Good evening, ladies and gentlemen. Thank you very much for being here in this magnificent building. It makes us proud to be Nova Scotians. We're grateful that you would join us tonight. My name is Bill Bean with the QE2 Foundation, and you're in for a very thought-provoking evening.
And my name is Jennifer Gillivan, and I'm President and CEO of the IWK Foundation. And we have a very impressive program for you tonight. 10 presenters from the IWK Health Centre, QE2, Dalhousie, and Acadia University, as well as NASCAD and a community member, are going to share their hope for healthcare and how their research and innovative ideas are going to help us achieve that vision. We have also a graphic facilitator, Susan McLeod, with us, who is visually capturing these ideas and hopes for our healthcare system on a canvas tonight, so be sure to check her masterpiece out throughout the evening as it unfolds.
Tonight is all about celebrating Nova Scotian researchers who are using strong evidence that they've discovered to improve the delivery of healthcare services and patient care. Their ideas are moving our healthcare system forward.
Innovation can be found in every corner of healthcare. The speakers you will hear from tonight are the best and the brightest in their line of work. Their leading-edge ideas will influence the delivery of care, not only here in Nova Scotia, but across Canada and, dare we say, around the world.
The most impressive part for us is that all this research is being done right here, right at home in Nova Scotia. We have a lot to be proud of in Nova Scotia. We are truly showcasing excellence and tangible impact that research has directly on patient care. So on behalf of the QE2 Foundation and the IWK Foundation, thank you for joining us tonight.
Thank you, Bill. At this point, I have the honor and privilege of inviting my colleague, Tracy Kitch, President and CEO of the IWK Health Centre, to say a few words. Tracy.
Thanks, Jennifer. Good evening, everyone, and my name is Tracy Kitch. As Jennifer said, I'm the President and CEO at the IWK Health Centre, and I'm delighted to be here and be your MC for the evening. I'm going to be introducing you, as Jennifer and Bill said, to some of the people, the research, and ideas that are shaping the future of healthcare in our region. Tonight, we're going to hear from 10 women and men who have a strong drive every day to make our healthcare system better. We will hear big ideas, simple solutions, high-tech strategies, and low-tech answers to some of our most complicated healthcare challenges. Now, in keeping with our theme of innovation, we've wanted to change the way the information was being presented. So we've really put them to a challenge, these talented individuals you're going to see tonight. As a result, the speakers have to deliver their presentations in something called Petcha Kucha style. So if you can all say that, you've passed already. But with only 20 slides and 20 seconds for each, they'll have less than 7 minutes to explain their ideas to all of you. This means we have a fun, fast-paced, entertaining, and informative evening ahead of us. But to keep the energy flowing, we won't be breaking for an intermission. So I do encourage those that need to get up or stretch, feel free to do that at your own leisure. We would also encourage you to share your thoughts over social media throughout presentations. To post and follow along, we're using hashtag #HealthResearchNS. And as well, the Chronicle Herald is also here live streaming the event for us, and we welcome those joining us from home. So now I think it's time to get the evening started. Each of the speakers I'll be introducing, as Jennifer said, are leaders in their fields, and to list their accomplishments would probably take their whole 7 minutes. So instead, I'm going to also keep with the Petcha Kucha style and keep their introductions brief. So the first speaker of the night I'm pleased to introduce is Dr. Robin Urquhart. And luckily for Robin, her 7 minutes doesn't start till after I'm finished introducing her. She's an assistant professor and radiation scientist in the Department of Surgery at Dalhousie University, and a senior scientist with the Beatrice Hunter Cancer Research Institute. Robin's research focuses on understanding how scientific evidence becomes clinical practice in hopes that important discoveries reach more people more quickly in a more lasting way. Over to you, Robin.
Our understanding of disease prevention, diagnosis, treatment, and palliation has grown at an astounding rate. And Canadian researchers are often at the forefront of those scientific advances. At the same time, there's a gap between what is known, what's published, and what's actually done in healthcare. We often call this gap the research to practice gap, and it exists across healthcare sectors, conditions, and regions. So studies over the world have shown us that 30 to 45% of patients do not receive care consistent with scientific evidence. Related to this, it's been shown that it takes about 17 years for original research to make its way into routine care. For those of us here tonight, what that really means is that many of the tools and the technologies that are being put into practice right now, we knew about them 17 years ago when Swiss Air crashed off our coastline. Let me give you an example. In 1987, the same year that Michael Jackson released the album Bad, the National Cancer Institute in the U.S. issued recommendations asking physicians to screen all of their patients aged 50 and older for colorectal cancer, and that was based on emerging evidence at the time. In 2009, the same year that Taylor Swift sold more albums than any other artist not known as Michael Jackson, Nova Scotia implemented a population-based colorectal cancer screening program. So that was more than 20 years after those initial recommendations. So moving what we know into what we actually do is not simple, and it's not quick. And we know this. Think about how hard it is to get out there and go for a run and to exercise, when I would say most of us are aware of the benefits of exercise, and we accept the benefits. But what this gap means is that many of our patients do not always receive the best care possible. So why does this happen? What's going on? Well, moving research into practice requires change, and change isn't easy. Obstacles always seem to stand in the way. Sometimes the evidence itself just doesn't fit the setting. It's the wrong size. Sometimes healthcare providers and patients are not aware of the evidence. Maybe they don't believe in its value, or they really just don't know how to make it work for them. And sometimes providers, patients, and healthcare organizations just are not ready to take that evidence and put it into routine care. And of course, all kinds of organizational, economic, and political forces create an environment where it's really tough sometimes to take that evidence and put it into healthcare. Oftentimes, people who work within the system, they have so many competing demands, all while they work in an environment where all kinds of urgent things are going on. Yet we know we can find ways to bridge the gap between research and practice. I want to turn our attention to the cancer system, which is where I sit most of the time, and where I see a whole lot of opportunities. So we all know that cancer represents a substantial burden in our province. Many of us here tonight, myself included, have been affected by cancer, and we understand the huge impact that it has on patients and their families. At the same time, we also know that in Canada, we could improve cancer outcomes by at least 30% if we routinely used scientific evidence in practice. There are great examples here in Nova Scotia where we've led Canada in cancer care and control, and we have shown that it is possible to move research into practice. We were the first province in the country to ban tanning bed use for kids and youth, and that was based on sound, credible evidence. We're also the first place in the country to routinely and in a coordinated way test lung cancer patients for specific gene mutations. And this information is so important because it allows us to find the best drug for that patient's unique type of cancer. And it ensures that our patients here get the best, most cutting-edge treatments. But sometimes the research isn't there, and sometimes we just have to innovate. About 15 years ago, the cancer program here in Halifax saw an urgent need. Many of their patients just couldn't afford many of their drugs. pain medications and things like that, but also a lot of the high-cost oral drugs come into market, many of which cost patients thousands of dollars a month. So in 2005, they started an innovative position to help uninsured and underinsured patients access the cancer drugs that they need. Today, this position has been spread right across the country to help cancer patients access drugs. So these examples all exemplify the ingredients that are needed to change practice. Commitment from system leaders and frontline staff. Champions driving the change. Cooperative relationships and partnerships both inside but also outside the healthcare system. And teams that value research and evidence-informed care. So we know that the obstacles to moving research into practice are not impossible to overcome. My hope for healthcare is that we focus on supporting our people and our systems in change so that all Nova Scotians have access to and benefit from important scientific discoveries. The time to do this is now. We have the oldest population in the country. We have some of the highest rates of chronic disease. We've just had a major healthcare restructuring. All of these provide the motive and the opportunity to work toward a culture of health in our province. And here's something else. We can get there. We have a robust and growing health research infrastructure. We're a small province. That means we can more readily take new ideas and evidence and move them into practice. And we've demonstrated a capacity for change. Sometimes that's by necessity, but we've shown we can do it. So take the leap. Become engaged in research, in those big projects so full of potential. Support innovation and support efforts to keep us all healthier from birth until the very end. Such a commitment, I do believe, on all of our parts, might just be the breakthrough we need to improve our population's health and to strengthen our healthcare system. Thank you.
Our next speaker is Dr. Brett Taylor, an emergency department pediatrician at the IWK. He also manages the Center for Therapeutic Technology at the IWK and acts as informatics director for the Department of Emergency Medicine at Dalhousie and as a lead physician informatics lead at the IWK Health Center. Brett's research combines these two worlds using knowledge of patient care and information about patients and professionals to improve the care in our emergency departments. Dr. Taylor.
Hi, folks. How we act depends on how we see things. Don Berwick has said that there are no shortages in healthcare. He says we have loads of patients, bags of problems, and that means that we have no end of opportunities. It's a great message and one that I hope you'll see reflected in my talk tonight. There are about 30,000 visits each year to the IWK Emergency Department, some for injury, some for illness. All of these are important, but about 2/3 of them are for low-risk, low-complexity conditions that don't decline in our waiting room, and that means in a busy department, they often wait for care. And these waits can be rather demoralizing. Most of these children wait between 1 and 3 hours before they see a doctor. 1 in 6 will wait longer than that. Low urgent kids will wait twice as long in the waiting room as they spend under the care of a physician at the back. It's no surprise to see that waits are a major issue for our department. While they wait, kids fret. We know that most of the time their anxiety is unwarranted, but it's pernicious and common and can cause major problems down the road. It's not unusual for the fear of emergency care to become a bigger problem than the condition that brought you to emergency in the first place. While they fret, paradoxically, they get bored. We have no tollway boxes in our waiting room. They're just germ distribution centers. And so consequently, we end up with bored, cranky little cowboys who become really quite difficult to assess and to treat. And finally, the wait is often pointless. We can start care right in the department for things like pain and dehydration, but we don't often, because when waits are longest, our emergency nurses are the busiest. We can see that problems with these sorts of protocols would provide care for these patients, would provide some reassurance for their long waits. So know shortages in my department. We have loads of patients who need care, bags of parents who'd like to take care of them. And the question is, how do we make them come together? Our answer is an information system game that has been produced by our tech partner, Everidge Incorporated. iCare Adventure is first a game. It's played on iPads that are distributed when the kids arrive and are cleaned when they depart. Children manufacture their own avatars. They fly to different parts of a big grid that's displayed on the wall, pardon me, and they are entertained by Buddington, the IWK clown. They can communicate with each other. They can offer games to each other. They can send shrouds of hearts to each other if they feel that they need some support. Play is a natural part of childhood. If you give a child a circumstance in which they're playing, it's intrinsically less frightening. iCare is also information. We have videos that are selected specifically for the patient that demystify, debunk, and reassure. A child has a cut, for example, may very well see a video that describes how wonderful blood is, how those little platelets grab hold of each other and pull together into a clot. It's also treatment. We have patients who are asked to measure their pain intermittently, and if that pain is high, the system automatically notices this and sends a reference to nurses who can intervene. Dehydrated patients are taught to use and like Pedialyte and are reassured and encouraged to continue to use it. Many people contributed to this. The IWK ED was a host. Everidge was a very, very generous sponsor for us. Marianne Hiltz was an early champion, and an IWK trick grant funded our research. Many others contributed to pushing this forward. So it's all very well to want to blow up the emergency department, but we needed to know whether there was evidence that what we were doing was correct. We're an evidence-based shop. We wanted to know if our toy would actually work to help improve health. We asked, therefore, if we exposed children to our device, did their satisfaction improve? And we found that generally the answer was yes. Satisfaction was much better in those who used the device compared to those who didn't. We also found improvements in pain control, and perhaps because they were so much easier to assess, improvements in the number of blood tests that we ordered in the back. We're hoping that as we move forward with this, we'll be able to extend these advantages to things like observation time in the back and perhaps even admission rates. We had lessons to learn. Not all of our children seem to understand our messages quite as clearly as we would have liked. We had a tighter game process would probably result in a better engagement with our kids, and so as a result, we're working on that. And finally, the expected gastrointestinal epidemic didn't occur last year. Sometimes poop just doesn't happen. And so we haven't had a chance to measure our Pedialyte trial. But by and large, we've moved from here to here. We've proven the concept, and we're pretty happy with our process to date. So, how far can we push this? Well, the next version of this project is going to provide asthma, concussion, and injury prevention protocols right in the waiting room. And there are other pathways that we can consider. Maybe one day, waiting rooms will become tech-enabled learning spaces where parents can come and learn how to fix their kids themselves and then get rubber stamped by somebody like me before going home. If you really want to push this, though, ask why you need an emergency department at all. If we can deliver e-therapeutics and information to the waiting room, why can't we deliver it to a kid's bedroom in Digby? Is it possible that we can do excellent pediatric acute care without any emergency care at all? Regardless of that, it's obvious that our obligation is to respect these children. Pointless waiting isn't respect. My hope, my wish, is that information and gameplay will transfer waiting rooms from places where we contain children to places where we empower them. Thank you very much.
Next up is Dr. Stacy Aykroyd. Stacy is an occupational therapist and health services researcher in the Department of Emergency Medicine at Dalhousie University. She's also an affiliated scientist with the Nova Scotia Health Authority, where she does research at the QE2's Charles V. Keating Emergency and Trauma Center. Her focus has been on patient safety and improving the experience of care for older patients in the emergency department. Stacy?
Most of us don't ever want to be a patient in the emergency department. We hear all kinds of stories about them. We were all concerned about the very first slide and messing up, and here I've already started, so I've broken the ice for everybody else who's sweating it back there. The emergency department, we all hear lots of stories about them, and they can be busy and crowded, and we all know about the very long waits. Many seniors visit our emergency department every year at the Halifax Infirmary, over 16,000 last year alone. Seniors often present with more complex illness and chronic medical conditions. Many have to be admitted to hospital. The number of older people seeking care in the emergency department is expected to grow. We were inspired by a program in an emergency department much like ours, but in New York City. It is called the Care and Respect for Elders in Emergencies, or CARE program. Trained volunteers spend time with older patients who'd like to have someone with them for part of their long stay. As in New York City, we too are very concerned about the effects of crowded conditions and long waits for sick older patients in our emergency department at the infirmary. It's also called the Charles V. Keating Emergency and Trauma Center. We thought that the CARE program had potential to work here. But the Big Apple isn't quite Halifax, it's different. So to begin with, what we wanted to do was to be able to understand what it's like for older patients in our emergency department, both from the perspective of those seeking care as well as those providing care. We partnered with Caregivers Nova Scotia. This is a province-wide organization that supports unpaid family and friend caregivers and their care recipients. Many of their clients are seniors or are providing care for seniors. It is a wonderful organization. And speaking of wonderful organizations, the QE2 Foundation and its counterpart at the IWK provide funding for research such as ours through the Translating Research into Care, or TRIC grants. One of the key ingredients for success is the involvement of patients, families, frontline providers, and people who manage resources in the system. People come to the emergency department because they are sick or injured. From our research, we learned that for many older patients and their families, there's a lot of uncertainty and fear about the unknown diagnosis. And this can be coupled with anxiety about wondering whether a patient can even go home. The emergency department can be a very lonely place. Many seniors spend a longer time there for a variety of reasons, like having extra tests. It's difficult for people to understand how things work in Emerge and why things take so long. Time goes very slowly. On the other hand, we heard from people working in the emergency department that there are so many competing demands that they must constantly prioritize. Some of them are understandable, like doing CPR on somebody who is having a cardiac arrest. But other important aspects of care include things like advising about medication or providing follow-up care. We all want safe, high-quality care for seniors in our emergency departments, but sometimes the many competing demands and priorities make it challenging despite everyone's best efforts and intentions. Is it possible that the CARE program could make a difference here? Every person who participated in our research fully supported the concept of the CARE program. They gave us many practical suggestions for implementing the program, like carefully selecting volunteers and training them well, and communicating about the program regularly. So, as a result of the research, we launched the CARE program at the Halifax Infirmary last November. We have 7 volunteers, and we are still recruiting, by the way. And each volunteer was carefully selected for their compassion and their respectfulness. The volunteers spend time at the bedside with patients, providing support, hearing devices, reading glasses, reading materials, a cup of tea, all to make a patient's stay as comfortable as possible. Not everybody wants a volunteer, nor do they see all people. But for those who do spend time with the volunteers, an empathetic listener makes a big difference. Volunteers offer a very valuable presence. One volunteer noticed on a monitor that a patient's very high heart rate settled to a normal rate just as they spent time together. Our research is just beginning. You're going to see in a moment our wonderful volunteers. This isn't everybody who helps to make this program happen, but they're fantastic volunteers. So I want you to take a close look at them. Because they make the program work. We've learned that sometimes low-tech works, and often for less cost, so it's more sustainable. And this has allowed us to just go ahead and do the work with the resources that we have. There is no dedicated budget for the CARE program. But that's okay, because it's been a lesson in valuing good old-fashioned frugal resourcefulness. And we don't know when there are going to be new healthcare dollars. But we do know that our approach to change is it's being resonating and happening in other parts of the world. For all of us who want to change healthcare, change starts here with ourselves. It takes innovation starts with heart. What that means is that you have to believe that change is possible and that change is worth it. And in our case, it's care and respect for elders in emergencies. Thank you.
Thanks, Stacy. Up next is Dr. Andrea Murphy. Andrea is a pharmacist and a Dalhousie faculty member. She's particularly interested in mental illness and addictions care and is currently working with people across Nova Scotia to capitalize on the potential and possibilities for community pharmacy-based mental health care service delivery.
I am a pharmacist and I am a researcher. My hope for healthcare is that we use all disciplines to their full scope of practice in collaborative, patient-centered care. This also includes helping those who are most vulnerable and marginalized get access to the care that they need. We have over 300 community pharmacies in Nova Scotia. What does that mean? Pharmacists are accessible. They're often available at times when other healthcare service providers might not be, so weekends and evenings, and they're dispersed across Nova Scotia. Pharmacists are medication experts. Did you know that medications are one of the most commonly used technologies in healthcare? It's estimated that over 75% of doctor visits end in a prescription for a medication. It's also been estimated that 41% of Canadians aged 6 to 79 years of age have taken a medication in the last 2 days. So all these prescriptions come to the pharmacy. I think we all have connotations of what a pharmacist might do: count, stick a label on things, pour from one bottle to another. But we play critical roles in medication management, and we're engaging in new services such as the flu shot, for example. I pitch to you that pharmacists also play an invaluable role in mental health care. It seems like a natural fit. Medications are very commonly employed interventions in mental health care for getting people to get well and stay well. Say if these 300 prescription bottles represented all of us in this room tonight. Those red 21 represent the folks that took an antidepressant this morning. This is Princess Leia. I'm going to read you a quote. She's Carrie Fisher. She says, "I'm fine, but I'm bipolar. I'm on 7 medications, and I take medication 3 times a day. This constantly puts me in touch with the illness I have. I'm never quite allowed to be free of that for a day." I bet you each one of us knows someone like Carrie Fisher, because mental illness is common. Our 40 Lego friends here, well, based on current statistics, 8 of them will experience mental illness directly this year. In Nova Scotia, 200,000. In this room tonight, say there's about 300 of us, 60 people. So mental illness is common, and there's lots of work to go around. So as a pharmacist, I'm interested in how medications are used in mental illness care, why they're not used enough, sometimes why they're used too much. And that's part of the story of why I'm here to talk to you tonight. However, I want to stress that medications are often imperative in the recovery of people with mental illness and addictions. It helps them on the road to get well and stay well. Several years ago, I worked with families and youth with mental illness. One thing that I recognized was that medications such as antipsychotics seem to be used more frequently than I would expect. Talking to colleagues, looking into the literature, I couldn't quite make sense of it, and I still had unanswered questions, so we studied it. And we did indeed find in community services recipients in Nova Scotia youth, the rates of antipsychotic prescriptions were higher than we expected. However, it was on par with a national trend. So then we did some qualitative work because we wanted to talk to physicians, we wanted to talk to parents, and we wanted to talk to youth. What we found is that sometimes the medications were used as Band-Aids or a bridge to another service. Youth had significant gaps in their knowledge, and the parents actually could have used a bridge to have more support. So being a pharmacist, I said, how can we as pharmacists help? Not just these folks using antipsychotics. And we started the More Than Meds program in a small number of pharmacies to build capacity with pharmacists working with people with lived experience of mental illness in their communities. We wanted to make things better for access to care. One of the striking findings for us that you might not find published in a paper is that pharmacists built amazing bridges with people in their communities, and what we recognized was there's power in the people in terms of recognizing and knowing where the resources are in their individual communities. And they were able to help the pharmacists recognize this as well. This is a resource that we developed with other people in the community, and it's called the Navigator. The Navigator is used by pharmacists and their patients to help patients find resources in their communities. Mary, for example, was a patient who was caring for her husband with dementia. She actually needed help and access to services in her community, and by going through the Navigator with the pharmacist, they were able to find some supports for Mary. So all these lessons learned we've put into our Bloom program, which is a program similar in principle and philosophy to More Than Meds. Pharmacists are working with people with lived experience to make care more accessible and better in their communities. This is an example of a library that the Bloom program requires in the pharmacy setting. One of our pharmacists in Cape Breton have put out a lot of references about sleep and recognized that in his community people wanted more advice about sleep. So he's been helping people, along with doctors, to work together to improve sleep quality and also decrease the use of sleep medicines. Another striking area which we were alerted to is the community pharmacist's role in suicide. Some of you may be aware that medications are commonly used in suicide attempts. Pharmacists have been required, sometimes on the fly, to help people who are present in a crisis situation. This wasn't new to us, though, because people with lived experience of mental illness have been telling us for a long time, frontline care workers, like pharmacists, need to have the knowledge and skills to be able to help refer people when they present in crisis situations. So now we're working on that. Now, all of this work that we've been doing, certainly change doesn't come without challenges, and so we've had some turbulent seas, but we look to the present lessons learned and also to the future to see that rainbow, and we strive to do things better and we strive to do things differently. And I'm hoping that with the examples I've given you tonight, you can see that pharmacists are more than just count, stick, pour. So what I'd like to also say is that I started by saying my hope for healthcare is that all disciplines are working to their full scope of practice and collaborative patient-centered care. The force is strong in pharmacists, and benefit we will when they are more than meds. Thank you.
Next up is Professor Glenn Hogan. Glenn received the Mayo Clinic's Research Fellowship in Healthcare Innovation in 2012. He's an Associate Professor of Design at the Nova Scotia College of Art and Design, and his background is in the area of human factors, productive development, and design thinking. Glenn is currently developing products for an aging population, and his work has been featured in the Wall Street Journal and on the PBS series Life Part 2. Glenn.
So what does design have to do with it? Well, I think everything, because in fact we all design. What I want to do in this talk is reframe design for you to show its value in healthcare. But I'm going to first talk about 3 stories that as a designers I have with healthcare professionals. And the first story usually goes like this. We need more art on the wall. And I agree, we do need more art on the wall. And this is a very loud, very long. And I do agree, we do need more art on the wall. But I'm not a fine artist, I'm a designer. But I never hear it framed as this. We need more art because of the healing process of art in providing or alleviating pain and suffering in the patients and the people that work there. The second conversation goes like this. We need to liven up our hallways. And I agree, and usually they mean painting it, but I'm not an interior designer, I'm an industrial designer. But I never hear it like this. We need to design a healing experience in the environments of our hospitals. Here's the third conversation. Glenn, we have a product. Can you make it sexy? Can you make it look good? And I probably can, but that's not the issue healthcare is having. Healthcare is not about designing products, it's a design service problem. Because healthcare is a service. And I was hired when I went with Mayo Clinic as a service designer. And this is how they're defining healthcare and the value of design. It's about design thinking. It's about a creative problem-solving approach. And I want to talk about that. And so what is design thinking? Well, effectively, it is using the tools of designers, such as prototyping, such as ethnographic research, by combining the people-centered approach, a human-centered approach, the viability of the organization, and technology to innovate. And that's essentially design thinking and the tool sets that designers bring in. So at the Mayo Clinic, they've actually created an innovation center where they're combining doctors, they're bringing in designers and administrators to take a design thinking approach, because that's how they think they're going to innovate healthcare, and solve the problems that they have from the service perspective. So, for example, they looked at their outpatient room, and they found that 90% of the interaction with the doctor is a conversation, and only 10% is in the exam room. So they actually redesigned one exam room and had 2 conversation rooms, because that's where healthcare is happening. And this is a little bit of the equation that they're using and why they see design as a fit. Because healthcare is patient-centered, design, we call it user-centered, and what they want is a human-centered solutions to the problem of healthcare. And I think that is where the value of designers come in. And this is essentially what a design process looks like. You empathize, you define, you ideate, prototype, and test. For the next few slides, I'm going to talk about some of my research around the empathy issue and about the user-centered perspective and research that I've taken over the years. So a few years ago, I worked for a company in the States called Herman Miller, and actually went into hospitals. And I identified all of you can call them workarounds, I call them creative solutions, people within hospitals, and I bet you'll find it here, are doing. The company valued it because they wanted to find out, innovate their line for their hospitals. The year later, I actually went with the Mayo Clinic, I went into seniors' homes and found all the creative ways that they were adapting their environments. The Mayo Clinic was interested in this because it showed them all of these creative ways people are solving a lot of its healthcare problems. And the great thing about empathy is that when you do it from a user-centered perspective, you get lots of solutions. And I also develop empathy tools for my students and myself to try to understand. Yes, you have to talk to people, but sometimes how do you empathize in other ways? Interestingly, this tool now I do a lot of workshops on ageism because it brings up a lot of ageist attitudes when I both wear it. But those are some of the tools that designers do because we can prototype things. It's helped me reframe how I design. For example, in this case, empathize, well, I talk to people that are managing their medication. They help define the issues for me. Then I brainstorm a number of solutions. We build stuff. Then you test it. And then you bring it back to the people and get it refined. And this has helped refocus about how I design. So instead of designing medical products for a commode, I now design human-centered products. And they look quite different because you're approaching it quite differently about what is the value to people in products and what they want. Here's a product I never thought I would do. And people indicated they needed this, a self-wipe aid. So on one side, you've got someone designing it for function. But what they wanted is a product that was designed for dignity, because that was the issue that they were designing for. And so what design thinking does and what it does for me, it helps refocus what you're really designing for. And as I teach my students, I'm really pushing that idea of it's a human-centered approach in design. It's a collaborative approach. Talk to people and design around that. So I'm going to talk to, there's a few clients we've worked with. I'll talk to some of the things we do and show what design at NASCAD in is 2015. So we worked with the Victoria Order of Nurses, and we looked at their Vial of Life program. And some of the things we use is systems mapping to help them understand it. We will then storyboard out that experience for them, and then story about a preferred experience for them. And that helps them understand their system and about it. So that's one of them. A couple of years ago, we actually worked with probably some people here. We went into the Capital Health, the hospitals, and we actually identified how you collaborate. And we created a taxonomy of collaboration, because we know that's the value of how healthcare innovation happens, within your own hospitals. So ultimately, what I would like to do is at the end of the day, I want to put 2 new ingredients in the healthcare fridge in Nova Scotia. I want to put designers as one of the ingredients at the table, and I also want to put design thinking as a methodology that all of us can use to help innovate healthcare. Thank you.
Next is Dr. R. Lee Kirby, a professor in the Division of Physical Medicine and Rehabilitation in the Department of Medicine at Dalhousie University, with cross appointments in kinesiology and community health and epidemiology. His primary research interest is in the area of safety and performance of wheelchairs, and he heads the team at the QE2's Nova Scotia Rehab Centre that developed the Wheelchair Skills Program, a training program for wheelchair users and their caregivers. Over to you, Dr. Kirby.
With serious mobility problems, wheelchairs allow people to get from A to B, and that allows them to live their lives and to participate fully. But they're not without their problems. People have overuse injuries of their shoulders. They tip over and injure themselves, frequent repairs. They need to learn wheelchair skills to be able to use the wheelchairs effectively. This is the website for the Wheelchair Skills Program, and I'm going to tell you a little bit about the origin and evolution of that program over the next few minutes. I hope some of you will take a look at this. We've had a lot of fun doing it over the years. It all began in the early 1980s with this problem, which was when lightweight wheelchairs first came out, and we noticed they were tipping over more often than they really should have. We used a simple research study to determine that, in fact, it wasn't the light weight of the chairs, but rather it was the axle position that seemed to be making the difference. That got us hooked. We then took off and did a lot more static stability studies using a platform such as this one here, in fact, that we designed. One end of the platform gets lifted slowly until the wheelchair tips over. The angle of the platform from horizontal is the static stability limit. However, over time, we began to recognize that it wasn't static stability that was the problem. It was when people were moving. In this particular example, this gentleman is trying to get his wheelchair over a gap that we've created in the walkway, and he bounces off his anti-tippers, falls from his chair slowly, and you might think, oh, well, it's just a slow fall. But if you've had many years of inactivity, your bones are weakened, and that would be enough to fracture your femur in some cases. Fortunately, he wasn't injured. This was part of a research study. We went on to develop a dynamic stability scale shown here from left to right. Transient tip, where you just tip transiently. Then partial tip, where you end up at some position not quite 90 degrees from vertical, and a complete tip when you're all the way over. This has since been adopted by the International Standards Organization. This led us to the Wheelchair Skills Test, which is a set of 32 different skills that people perform that mimic everyday life. We did this, of course, looking for safety, but we pretty soon found that people couldn't do the skills we thought they should be able to do, which of course led us to why not train people in how to do this better. That's the Wheelchair Skills Training Program, which consists of two parts: the best research evidence on how to teach, the process, and the content to teach. Those two together make up the Wheelchair Skills Program, the Wheelchair Skills Test, and the training program. I'm going to show a couple of examples, one of the process and one of the content in terms of the research evidence. The first one here is a learner breaking up a skill into the three segments. The middle segment is just popping the front wheels up onto the curb to allow her to be able to get that straight, using a mirror as augmented feedback for that before putting the various parts of the skill back together. That's motor skills learning, one example of it. The next example is content. This gentleman who has a spinal cord injury that has affected his use of his arms but has left his legs intact is able to get up this incline backwards more easily than forwards. And this is a research finding that we had in our own lab here in Halifax that sort of documented that this is generally the case for people who foot propel rather than hand propel. Now that you know what the Wheelchair Skills Program is, what about its impact? Well, based on its website statistics, this is a Google map, almost 60,000 people from 173 different countries have used our website since 2007. As far as impact related to publications, coming up in the next slide, this is the publication page from our website. There have been 64 peer-reviewed publications so far about our program. We're very pleased that about half of those were ones that we've done ourselves, but we're even more pleased that the others were done by other people around the world who are using our program. And we're very, very pleased about that. The next impact slide has to do with groups that have adopted our work and including it in what they do. So on the left side, there's the Canadian Spinal Cord Guidelines, which include our work, the Australian guidelines, the international guidelines, and the World Health Organization is picking up on this work as well. There are also some non-governmental organizations that I don't have time to mention. How do we use the Wheelchair Skills Program here in Halifax? We use it for our patient care, we use it in our research, we use it for education. This is a boot camp, a conga line where we put students through, some 300 a year go through our training program in the Mobility Center at the basement of the Rehab Center. This was paid for by the QE2 Foundation. We're very grateful for their help. We also do this type of training boot camps around the world, and you'll notice from this distribution that they're both highly resourced settings like Europe and North America, but also those with very little in the way of resources. And we're very pleased at that this is a low-tech, high-impact intervention that allows us to do it. Here's an example from India. This gentleman with spinal cord injury, using not the greatest wheelchair, has had spinal cord injury for 13 years, did not know how to get up a curb. After 5 minutes, he could. What's amazing about this is we didn't speak Hindi, he didn't speak English. It was all done with gestures and demonstration. This is something else we've learned from our travels, is how to teach better. This is what we call the chorus line. We line people up and do it all at the same time. And the reason we've learned to do that in Bosnia was because we were using a translator, and rather than repeat things many times, just having everybody do it at once just seemed to make more sense. We brought that back to Halifax and all the other work we do. We've also had a chance to work with some people who are very talented around the world. This gentleman is one of the peers we are training to teach other people with spinal cord injury how to live their lives and how to do wheelchair skills, and he already arrived able to come down a steep set of stairs in a wheelie position. Very humbling to work with people like this. So in summary, this whole thing began as one research project. It's involved 30 years of work. It's involved hundreds of research colleagues and students working with us, thousands of research participants and patients, millions of dollars in research funding that we've had from groups like the QE2 Foundation, but from national and international bodies. What does the future hold? Well, I hope you won't, in 25 years, no one will know what the Wheelchair Skills Program was. It'll just be part of standard care. Every person who needs a wheelchair will get one. They'll get trained in how to use it properly to be able to use it most safely and effectively. Thank you very much.
Next up is Dr. Jonathan Foulkes. Jonathan is a professor and exercise physiologist at Acadia University, whose work in the Center of Lifestyle Studies examines the effects of exercise on health in athletes, the elderly, and persons with chronic disease or disability, including diabetes, hypertension, and obesity. He works tirelessly at promoting strategies for assisting healthcare professionals with incorporating exercise into primary care. Jonathan?
Thank you very much. All right. Now, I'm the exercise guy, so I'm going to give everybody a little break. And let's get everybody to stand up here. Get a little bit of moving going on. Yeah, let's lift those legs, maybe stretch the arms. There we go. A couple times, maybe sit back down. Stand back up. There you go. Get another one going. Good. And now you can sit back down. Great. Okay, so you're probably wondering why I asked you to do that. Well, part of my job tonight is to talk about exercise as medicine and how movement can contribute to your health. And just that little thing that we just did there broke up your sedentary behavior, and it has important effects. It removed a little bit of glucose from your blood. It took out some fats. It probably stabilized your blood sugar and your blood pressure. And it probably contributed to your mental health, which is also good now. See, there's irrefutable evidence that has been accumulating over the last 20 years that shows that when we accumulate physical activity and reduce our sedentary behavior, that it reduces the risk of most chronic diseases by anywhere from 25 to 50%. And that moving is something that contributes to our health in every way. Now, I'm that guy. I'm the guy that likes exercise. And that's me on my bike in PEI. And I got to say that being on my bike is one of the things that fills me with energy and with vigor, and I love it. And it's the passion that I bring to research and sharing this message with healthcare providers that I'm going to share with you tonight. But I got to say that I wasn't always like that. See, when I was a kid, I was a little overweight, and I was that kid in grade 8 that still hears in that school assembly, who rolled that kid to school? And I got into exercise to change my physical health, so much so that I went off to university to learn a lot more about it. And as I learned more about it, the more I figured out is that physical activity regulates every system of our body, from our brain to our digestive system, everything. Because historically, for thousands of years, we have moved a lot in order to feed this big brain of ours. And the absence of movement creates a lot of problems. So much so that now, even in today's society, we've pretty much engineered physical activity out of everything that we do, partly in the name of innovation. And this is a problem because we're paying for this convenience with our health because it robs us of our health. And we're actually going to be the first generation in history that likely will not live longer than the generation before us, mostly because of this physical inactivity. See, there's computers that permeate everything that we do, and we've gotten really good at economizing on physical activity in just about every way. And with, processed food at every corner, it's created this imbalance or dis-ease in our physiology that's creating all kinds of healthcare problems. And so why is this important? Well, because whatever's important to you, whether it's your work, your family, your friends, your kids, your hobbies, travel, whatever is important to you kind of can go away when you don't have your health. But you have the power to change it by choosing physical activity. And so is exercise the best medicine? Well, in my opinion, it is. And there's lots of really good evidence that shows that your fitness level is actually one of the best predictors of how long you'll live, how well you'll live, and how much you'll live your life with quality. And so getting physical activity is one of the best things that you can do and have the power to change your own health. Did you know that 1 hour a day of watching TV is the equivalent health risk of smoking 2 cigarettes? So imagine if you got a little bit more physical activity, maybe played a little bit more with your friends or your kids, or even got a little exercise in whatever way that you can fit it in. Well, imagine what that would feel like. And that's what my vision for healthcare is, where our healthcare system has physical activity and exercise as an integral part of health across the continuum, in whatever way it can be delivered by healthcare providers. And the other part of the objective of exercise as medicine is to have exercise professionals such as myself and kinesiologists and other physical medicine specialists to help in this, supporting you in that journey. Because just about every paper I've read shows that promotion of physical activity and exercise therapy is actually cost effective and can save our healthcare system millions of dollars, if not more. So what if, imagine a situation where your healthcare provider could help you on the right step towards a physical activity plan. And you had places to go at any time of the year that could help you to be active. And you had exercise professionals to support you in your individual needs, whether or not you have a chronic disease or are trying to get going to prevent chronic disease, from wherever you are to wherever you're going. So maybe this could be the situation. But then some of you are probably sitting there thinking, well, I don't want to go to a gym, and that's okay. You can choose physical activity in any way that you want, because we all have choices, and we all have a story. So I wanted to finish this with a little bit of story of my own, of how physical activity has also affected my life. See, there's my dad. At age 55, he was pretty fit and active, and as he went into retirement, like most people, he enjoyed a little bit more food and a little bit more, beverage and traveled and enjoyed his life. But then at 65, he had a major scare, severe coronary heart disease. And his brother died at almost the exact same time. And so I had a talk with my dad, and I said, Dad, I want you to be around in the future, to be with my kids, and to read them stories and play with them. And so your health is important. And so I said, let's get back to moving more, and maybe exercise is a way to help address this problem. And so he did. He got right back into baseball, and on golf, he walked the course instead of took a cart, and he hiked almost every day, and he even got into weight training. And I got 16 more years with my dad, and he got to play with my kids, which is a really amazing gift that you can give yourself and other people. So the take-home message here is that physical activity not only adds years to your life, but it can add life to your years, because it can contribute to living your life the way that you want to do it, and from wherever you are to a better place. So that's my vision for healthcare, is that we can support physical activity as part of your healthcare journey, and that we have places and professionals that can help you to live a better life, a better physical, mental, emotional life. So what I'd like you all to do now is, if you can, stand up and give yourself a round of applause, because the physical activity is good for you, and we all deserve it. I love getting standing ovations in my talks, because I always get everybody to talk.
That's very clever. I have to remember that one. Okay, next is Dr. Marcia Campbell Yo. Marcia is an assistant professor in the School of Nursing at Dalhousie University and a certified neonatal nurse practitioner and clinician scientist at the IWK Health Center. She works to improve outcomes for at-risk newborns, specifically related to pain, stress, and neurodevelopment. Marcia.
I went to work in the IWK's neonatal intensive care unit, or NICU, over 25 years ago because I loved the idea of saving lives with technology, the fast pace, the adrenaline rush. To me, good care for babies was all about technology. Now, it's certainly true that some of the babies who are surviving now did not survive when I first started. But the bad news is it comes with many medical procedures. Now, as a clinician scientist, I want to find ways to decrease the pain and stress associated with this technology. So why pain? Well, let's meet Jack, a typical baby that we care for in the NICU. Jack was born 4 months early, weighed just over 1.5 pounds, and spent 118 days in the neonatal intensive care unit. There, he endured over 1,100 procedures like heel pokes and needles and IV insertions. Now, it may come as a shock to you, but just 30 years ago, it was widely believed that babies didn't feel or remember pain. In fact, we actually performed surgery without pain medication, simply giving them medications to keep them from moving. Hard to believe. Well, today we know that babies not only feel and remember pain, but we know that untreated pain can lead to changes in how they perceive later pain, how they think, form relationships, and even how their brains develop. Sadly, studies tell us that less than half of babies in Canada and the world receive pain relief for these procedures. Solutions aren't easy. Drugs aren't the answers. Many drugs that work for adults don't work for babies. We had to find new ways. We have become so reliant in high-tech care and specialized drugs, we were underutilizing our most important resource, parents. So you may ask yourself, what's so innovative about a parent's touch? I can tell you that in the NICU, it's truly a new direction in which we've always provided care. Remember Jack? He also endured over 2,000 hours of maternal separation. So how could parents help? Together with my team and the support of a world leader in pain, Dr. Celeste Johnson, we conducted several studies examining simple parent-led strategies, like the upright holding of a diaper-clad baby on his mother's bare chest, to see if we can make a difference. This is called skin-to-skin care or kangaroo care. And through our research, we found incredible things. This not only decreased the pain that babies felt when provided during minor procedures, but it stabilized their heart rates, lowered their oxygen, improved their oxygen levels, and even helped them recover faster. We did studies looking at dads, other adults like grandmothers and aunts, and even examined whether a baby's preterm twin could help decrease the stress associated with these procedures. We determined it was more than just a mother's touch. Human contact was the answer. The best part was it helped parents too. Parents told us they felt better, more in control, more confident, less stressed. We're excited to actually be now examining the longer-term benefits of skin-to-skin contact. But we also wanted to find ways to tell other clinicians and researchers about what we and others had found. So we created a synthesis of all the science that had been done in the world about skin-to-skin contact and pain. We included 19 clinical trials, a third actually done here at the IWK, all reaffirming the benefits of skin-to-skin contact and human touch. But we wanted to tell parents too. Most didn't realize how powerful they could be. So we created a 2-minute parent-friendly YouTube video called The Power of Parents' Touch. It's been viewed now over 140,000 times in 120 countries, and it's been translated in 6 languages. We now know that parent-led strategies are safe, free, natural. They can be done anywhere, at home or in hospital. What we needed to do was actually be able to tell others and create a new culture of change. The IWK heard us, and they're leading this paradigm shift. Thanks to the IWK Foundation and others, we are now changing to single-room care, an environment that will allow families to stay close to their babies versus our current open bay design. But with new spaces, new ways of doing things comes challenges. How would we educate and engage families in this new space? How would we support them so they didn't feel alone? We needed new solutions. And this is where I come full circle tonight, because I believe balancing human contact with technology is actually the answer. I'm excited to be the new scientific director of the Shea NICU project. This is the first phase has been recently funded through a co-op, partnered with Cisco, is due to launch in 2016. We will address learning and education needs, keep families together, and improve efficiencies in the healthcare system. The background will be a virtual and secure online library of interactive neonatal care. Parents and IWK healthcare providers will be linked together, as well as to the homes of our families, local community providers, and those who support them, no matter where they are. So what does this all mean for Jack? Remember those 1,100 pokes and 2,000 hours of maternal separation? It would mean Jack wouldn't need to do it alone. Parents would have the skills, resources, support to be able to become integral part of his care. The message that I want to leave you with tonight is touch is not just a nice thing to do. It's been scientifically proven to improve outcomes for babies like Jack. My hope for healthcare is that babies here and around the world get the best of both worlds, technology and parent touch. Thank you.
Next up is Jerry Post. Jerry has spent his life as an urban planning advisor to organizations around the globe and has won both domestic and international awards, including the World Leadership Award for Town Planning and Urban Governance. He now claims to be semi-retired, that's in quotes, spending his free time helping many community groups, one of which includes his own initiative that aims to provide independent access to affordable technology at the Keeley 2.
Thank you very much for the very kind introduction, and I feel a little bit intimidated being with this wealth of expertise in healthcare. I was just a patient that saw a need and nudged the system to make a few things happen. It's a story about people who get disconnected because of disability. As some has stated already, we've got this gray tsunami that's hitting us. It's going to have a profound impact on our healthcare system and our governance. And the big challenge will be resources, and collaboration will be required, not just within Nova Scotia, but perhaps across the country, to fund things that are required. Along with it will come a disabilities riptide. Again, we lead the country in this. 20% of our population currently has a disability. It will grow to about a third by 2026. Very significant amount of people. Accessibility will become a huge issue in Nova Scotia. Becoming disabled can happen to anybody. It happened to me. I was working very hard in Grenada, as you see. And within a day or two, I was at the infirmary, at the emergency, with a chaplain standing over me, basically giving me my last rites. They saved my life. I'm blessed. Unfortunately, my condition put me in a wheelchair. Upon reflection, one of the big disadvantages being disabled is that you lose independence to a large extent. I'm fortunate. People with severe disability also become disconnected because of the difficulty of accessing technology, both communications and IT technology. This needs to be corrected. I'm a bit of a gadget freak, so when I entered the rehab center, I gave up a single room to be with 3 roommates because there was a router next door. And and this is where the story really starts. It's serendipitous in a way, what happened to me by taking some roommates. One of my roommates was an elderly patient in his early 70s who had fallen, broken his neck, and became paralyzed from the neck down. He saw me playing with my iPad in my bed and was asking about it. And within a few hours, I had him operating the iPad using Siri, the voice-activated system, and he ended up communicating with his granddaughter in Calgary. It opened our eyes. I had time. I was there for 3 months, and then when I was there, I was starting to do research on what was available for adaptable technologies. A lot is available. Some is very expensive, complicated, and we can't all be Stephen Hawking to operate it. And those with severe disabilities, many of them live below the poverty level. The other thing I discovered is at the rehab center, they excel at the traditional practices of physio and occupational therapy, but very little was happening on the IT front. I think what it is that it takes time for large institutions, professions, to turn their ship around. In the meantime, technology is accelerating at the speed of sound. This resulted in a proposal that I put together, which was accepted immediately by the co-directors of the center. And they appointed Kim Parker, who's standing in the picture there, as a part-time person to work on the project. And she takes all the credit, or should take all the credit for what you see in the future slides. We had 3 objectives. One was research, to find out what the best breed of technologies are out there. Second was to bundle them easily for clients. And third was to disseminate, including training. And these objectives are currently being met. We, of course, worked with various patients to refine the bundles. This is Linda. She's paralyzed from the neck down, and she's using 2 technologies, a switch under her chin and voice, to activate not just her computer, but also external devices like her television. Our next patient is Justin, severely disabled, could not speak. Here we adapted a technology called eye gaze, where the pupil is calibrated with the computer, and your eye becomes the mouse. And he became very adept at communicating with his family through doing that. Our third example is a lady, Catherine, who used her mobile phone to communicate. and activate various external devices around her home. It becomes very difficult if you cannot lift your hand to turn on and off the lights, simple things like that. And using the Bluetooth technology, this is now happening and currently available. Now, the United Nations a few years ago adopted internet access as a human right. Obama has initiated a major initiative to give free access to internet throughout America. Perhaps our government will follow suit. Our project is still very small. We're still playing in the sandbox, and we need to get out of the sandbox. And my hope is that we establish an IET lab, follow the example set by Dr. Lee Kirby with the wheelchairs, and move it into the next generation of technologies. And do it collaboratively, perhaps regionally, amongst partners. The vision that we have, and the hope that we have beyond that, is for it to be a collaboration between the community. I see community partners like the private sector, NGOs, academia. I also see our student population, perhaps in occupational therapy, to become volunteers, to train those in need using the technology. And I also see an opportunity for a social enterprise in this field. I will keep this under wraps for the moment. We have organizations, NGOs, like the March of Dimes, who've noticed this. They now have a free giveaway program of e-tablets to those that cannot afford them. It's very encouraging. But those recipients will need help to use and to be trained. Now, you remember Justin that I showed earlier. It's a bit of a bittersweet story. 3 days after this picture was taken, he passed away. Before he passed away, he was able to compose his thoughts and last wishes and say goodbye to his wife using the technology. Very powerful. And I'll leave you with this last thought. For most of us, technology makes things easier. For a person with a disability, it makes things possible. Thank you.
Next is Dr. Stephen B.A. Stephen is an imaging physicist and an associate professor at Diagnostic Radiology and Health Sciences. A scientific lead at Biotech, the Biomedical Translational Imaging Center located in the QE2 and the IWK Health Center, he's creating a research environment in which discovery science and applied sciences interact, with discovery research programs feeding new ideas and trainees into a research program that can create next-generation healthcare products. Stephen.
So I'd like to begin by introducing you to Tynan, or as he became known minutes before we took this selfie, Dr. Stevens. Tynan is this incredibly talented young Nova Scotian who, when he began graduate school, could have gone anywhere in the world. But because of the research going on in our health centers, he decided to stay here. And because he did, we launched a program of research that has led to the development of a new computer algorithm that takes medical images and turns them into a roadmap of the human brain with the potential to improve outcomes from brain surgery. This research is already changing care here in this province, and we're commercializing it in partnership with a multinational company. But it goes beyond that, because Tynan now works for the Nova Scotia Cancer Centre. He got married, he bought a house. And think of the lost opportunity for Nova Scotia if instead, like many of our young people, he had decided to leave and head west and, let's face it, likely never move back home again. And that's the impact of only a single example of healthcare research. But if we need to move beyond even single examples, we're going to have to, much like my son Jack here, decide that we are going to challenge convention. We've got to start thinking differently. And so tonight, I would like to re-examine certain things that we have long held as unchangeable truths about healthcare in the province of Nova Scotia. We should be exploring around and trying to look at things from a different perspective. We need to walk up to that large, seemingly immovable rock that says healthcare will only ever cost the province money, turn it around, look at it from the other side and say, but what if it could make us money? And the reasons for doing so are many. We've heard about many of them tonight. We have one of the oldest populations in this country. We have one of the most obese populations in this country. One of the highest rates of diabetes, one of the highest rates of many forms of cancer. The list, unfortunately, is long. We have serious healthcare problems, and we are going to need some innovative solutions. Now, these problems are compounded by the fact that after years of unsustainably escalating healthcare budgets, we are now told that we must begin to think always in a framework where we have to assume that there is no additional taxpayer revenue for healthcare. And that is a challenge for people like me looking to introduce new technologies into the healthcare system. It's not like new healthcare technologies are not coming out every day. It's not like they don't cost money. So we want access to the latest healthcare technologies. How are we going to do it? I like to put things in simple terms that I can understand. And for me, in simple terms, the provincial budget is absolutely no different than our household budgets. And if healthcare were my household budget, I would just sit down with a piece of paper, and I would write down on one side all the things that I think we need, and I'd write down on the other side of the piece of paper all the sources of money that we have to pay for those things. And if it didn't add up, then I'd have to think outside the box of, well, then how are we going to generate the money required to pay for those things that we need? Because in a publicly funded healthcare system, we cannot separate out our ability to deliver healthcare from our ability to generate the economic wealth needed to pay for that healthcare any more than I can separate out how nice a house I can afford from what my household income is. This is the Ivany Report put in a healthcare context. A different way to think about it would be to paraphrase James Carville's famous whiteboard scribblings, his advice to Bill Clinton on the eve of the presidential debate, in which he famously said, and I paraphrase, "We're in desperate need of change, and don't forget, it's all about the economy and healthcare." So where do we go from here? Well, one way that we could think outside the box would be to look for those opportunities where healthcare and health research working side by side could leverage each other, purchasing or even operating equipment that neither could independently do on their own because they can't afford it. And we have great examples of that. Just this past year, we have the example of the QE2 Foundation providing the funding needed to buy a brand new 3T MRI. And the problem is that neither the healthcare system alone nor the research enterprise could afford the nearly $500,000 it takes to operate one of these pieces of equipment. But through a unique partnership between the two, both now have access to this cutting-edge technology at effectively half the operational cost. Now, it's great, but I don't want to spend too much time tonight talking about how we can save money. I want to spend time tonight talking about how we can use health research in this province to make us money. And we have great examples of that, too. I have a personal example coming out of my own research lab in our recently announced partnership with General Electric Healthcare. This 5-year partnership and the nearly $3.5 million in total research investment that it has leveraged has led to 12 high-paying knowledge economy jobs that will last at least 5 years. It will generate 3 new healthcare technologies, which, if successfully commercialized, will lead to ongoing royalty revenues that are going to flow back into this province's healthcare system. And GE could have gone anywhere in the world to launch such partnerships, but they didn't. They came to Nova Scotia. And the fact that they did flies in the face of an often heard assumption that we hear far too often, which is that we are too small in Nova Scotia to compete with the big players on the big stage. And it simply is not true. When it comes to health research, it's not about being the biggest. It is certainly not about who has 10 of the latest research technologies. It is only about who gets to cross the finish line first. And in being small, we can be nimble. We can think outside the box and do things differently. And I would argue that when it comes to health research, small should be the new big. Now, I began with the example of Tynan Stevens and the impact that even a single example like that can have. And we took this up to the level of a multinational partnership and the impact that that can have. But it is still fair to ask the question of, is it simply my fantasy world that somehow we could take and have health research as an economic engine at the level of the entire healthcare system? But as we've heard tonight, innovations are coming out of our healthcare system every day. And if we took even some of those and used them first to improve healthcare here at home, and then exported those solutions to the world, we'd really have something. Every one of these local companies shown here is driven by research that is going on inside of our hospitals. When Nova Scotia invests in healthcare, it is not only an investment in saving lives, it is an investment in the future of this province where young people like my son could stay here and create new healthcare innovations that lead to better healthcare and a better economy for this province. Thank you very much.
Wow. We have innovators here in Nova Scotia. My name is Dr. Patrick McGraw. I'm the Integrated Vice President of Research and Innovation at the IWK and the Nova Scotia Health Authority. On behalf of our presenters, I'd like to thank you for attending this evening. Thanks to all of you who have tuned in on the Chronicle Herald website, and we've had people coming in from all over the world. We're also, they tell me, trending on Twitter. I don't know what that means, but I think it's good. In the days ahead, we'll be archiving these presentations so they'll be available to watch on the Herald website. Often, the prevailing narrative in Nova Scotia and the rest of Canada is that healthcare is a burden on public finances and that research is a luxury. There are rarely opportunities such as this to focus on the successes or improvement of healthcare through research and innovation. Last year, we had an inaugural Research and Innovation in Healthcare Forum. We heard from Danielle Martin. I think some of you were there last year, and she shared us about her 3 big ideas for transforming healthcare. This year, we wanted to share our own big ideas. We wanted to focus on new research and innovative ideas and opportunities that have started here at home in Nova Scotia. Tonight, we heard from 10 individuals who shared their innovative ideas and ways to tackle 10 complex health system problems that we are faced with every day in this province. They are but 10 of the hundreds of people working on solving these problems here in Nova Scotia. We could have put on 30 people or 40 people giving you presentations tonight. And that is not to mention the thousands of people that volunteer to take part in health research in the region and the number of health professionals and medical students that are trained here. We all play a role and we all make a difference. I want to pay a special thanks to our MC, Stacy Aykroyd, CEO of the IWK Health Centre, Bill Bean, CEO of the QE2 Foundation, and Jennifer Gillivan of the IWK Foundation for their opening comments. Special thanks are also to the event organizing committee and the event sponsors who saw the potential in this idea and made it possible to bring everyone here tonight, including the IWK Foundation, the QE2 Foundation, Research Services at the IWK Health Centre and Nova Scotia Health Authority, the Halifax Public Libraries, the Chronicle Herald for assisting with the online streaming, Basil Audiovisual, who made it possible for us to hear each other, and Susan McLeod for her beautiful graphics. Without these groups and their commitment to improving health care for this region, we would not be here. Please give them a round of applause. Finally, we want to hear from you. If you have comments or feedback on the event, please visit the Herald website. I won't read it out, but you see it right here, or just go to Google the Herald and you'll find them. Or you can fill out our quick survey, which is distributed, or give us some information to Elaine on this website, on her email. Or you can email me, Patrick McGraw. The speakers have agreed to stay for a while. If you have any questions, please join us. Come on down and join them here on the floor, and they'll chat with you. Thank you very much for coming tonight. Enjoy the rest of your evening. Thank you. Come on out.